of Ho Chi Minh City, Vietnam. And today I will present my two cases on hyperkinetic movement disorder. My first case is a 68 years old male who admitted to our hospital because of his abnormal movement on his right arm. 10 years ago, before admit to our hospital, he has mild dysarthria and dizziness and mild weakness on his right side. He was diagnosed with the left bronchial hemorrhagic stroke and hypertension. And after discharge from the hospital, he only had mild weakness on his right side with the modified Rankin scale was 2 points. But 4 years ago, he started to notice about his abnormal movement in his right arm. And this abnormal increased day by day and affect his daily activity. He usually used medication with blood 1,000 milligrams per day, but modest improvement was recognized. And after the hemorrhagic stroke event 10 years ago, his blood pressure was under control with amlodipine 5 milligrams per day. And on examination, I will summarize the patient has just mild weakness on his right side, with abnormal movement on his right side. We collect in the next video. The abnormal Babinski side and sensory deficit on the right side. Okay, you can see in this video, the patient has a rest oscillation of his right arm with flow frequency. And when in the posture, still the flow frequency, but the amplitude is increased. And next, when the patient moving by in action, the amplitude of this movement increase in maximum. Okay. Can you tell me this phenomenology of this? Can you tell me the phenomenology of these cases?
Yeah. So what is the phenomenology here? Tremor, dystonia, chorea, and what type? Anyone? Yeah.
Yes, at rest, the patient has oscillation movement in the proximal and distal right arm. You can see in this video.
Yes, sir. I think he has hemiplegism.
Hemiplegism? Okay, thank you so much. And you have another questions, another phenomenology for these cases.
The hemiplegism is more flinging type of movement. So you look at the phenomenology at rest and also at posture, and he gave a hint there. You want to play that again, at the one at rest?
Play again.
Yes, I will play it again. Okay.
Okay, may I?
Yes, please go ahead.
I think this case is compatible with Holmes' tremor, right?
Yes, Holmes' tremor.
Holmes' tremor.
Okay, that's exactly. Thank you so much. Okay. Yes. This case is illustrated of the Holmes tremor, which characterized by the rest tremor and with the flow frequency in the proximal and the distal arm. It increased the amplitude of the movement by in posture and the reach maximum when the patient in action. And this phenomenology is Holmes tremor. And we check again the patient's imaging with the all lesion in the hemorrhagic stroke at the left bronchi. As you can see in this MRI. And once again, I want to remind you about the one of the most important neuroanatomical regions in that causing this phenomenology is the Wheeler-Morales triangle, which consists of the ipsilateral dentate nucleus, contralateral at the red nucleus, and the contralateral inferior olivary nucleus. And each in any damage in this nucleus or any damage damage in the track connection between those nucleus can cause these abnormality. Okay, and one more questions about, can you tell me some phenomenology that have the same phenomenology like Hermes tremor that has the characterized that the rest tremor, action tremor, and postural tremor that you need to be differentiated in the clinical examination? Can you tell me? One of more specific have this maybe have some overlaps with the Hermes tremor in examination. Okay, can you tell? Okay, I will show the answer. It needs to be differentiated between Hermes tremor and limb myarrhythmia in clinical examination because of these two phenomenologies have the same presentation, like in the rest tremor and posture tremor and goal-directed tremor with the low frequency. As you can see in these images, Hermes tremor reach increase the amplitude of the movement, abnormal movement when it's postures and reach the maximum amplitude in goal-directed. But in limb myarrhythmia, when the patient in postural or goal-directed, the amplitude maybe remains unchanged or mildly modulated. Okay, we will. Next, here's the abnormal movement of this young man who admit to our outpatient department after 6 months after thalamic hemorrhagic stroke. As you can see in this video, the patient has a semi-rhythmic oscillation in his left arms with dystonic posture, and the semi-rhythmic oscillation of his left arm remains unchanged during at rest, posture, and goal-directed. And this patient have the diagnosis with limb myarrhythmia. And as you can see in this table, the Hermes tremor and limb myarrhythmia still have the same etiologies. Usually after the ischemic stroke or hemorrhagic stroke at the brainstem and the Guillain-Barré triangle. Okay.
Yeah, it's normally a very slow tremor, about 2 to 4 hertz. You can get it after a stroke, whether it's hemorrhagic or infarct, but you also get it in cases like NMDAR encephalitis, especially at the facial region there. So that has also been described.
Yes, yes. Okay, thank you. And nowadays, because the Hermes tremor, it causes a very disability for the patient. Therefore, the groups of authors suggest the possibility algorithm for the treatment. We can use the first line therapy like levetiracetam, trihexyphenidaine, or levodopa for treatment of Hermes tremor, or using the second line with the clonazepam or botulinum toxin injections, or combination of steam medication. In case of refractory of Hermes tremor, some authors suggest that DBS, especially in the GBI and VAM, for the control the symptoms of Hermes tremor. Okay. I will moving to the last case of my last cases. My last case is about 57 years old male admitted to our hospital because of his dizziness. He has the previous history of 10 months ago were diagnosed with the ischemic stroke. He had the my right side weakness residual, but recently about 2 weeks, he complained about his dizziness and imbalance when walking, but with no trauma. He has mild dysarthria, but no limb weakness increase and no ear click. On the examination, with my right-sided weakness and Babinski side on the right side, we can recognize the abnormal movement of the palatal. As you can see in this video, this is the rhythmic movement of the soft palate with the flow frequency. And in the presentation of Dr. Shireda, you can call it is a palatal tremor. But in this phenomenology, in the 2019-17, the classification of the MDS were using the phenomenology palatal tremor. But for some other authors, they use the phenomenology with the palatal myoclonus because just only the one muscle activate this condition. However, there's some another overlap between because there are some the other movement associated with the palatal tremor like the facial myarrhythmia. Therefore, some authors suggest the phenomenologies like the palatal myarrhythmia in those cases. And because of the patient's complaint of the new onset dysarthria and dysphagia, we recheck again the imaging of the brain. As you can see in this imaging, the lesion in the left midbrain, the lesion. But striking here is the bilateral inferior olivary hypertensity in the flare and T2 imaging. Without gadolinium enhancement, but I'm sorry, but I'm not showing here. And as you can see in this video, can you tell me what's with this imaging? What do you think about this imaging?
What's the abnormality in this MRI? Which structure is that?
Yes, so the bilateral inferior olivary with the hyperintensity in the flare and T2 imaging without gadolinium enhancement. Okay, nobody? Okay.
Yeah, in this case, the hypertrophic olivary degeneration.
Okay, thank you so much. That's correct. And this imaging is the cause of the bilateral inferior olivary hypertrophy, and we usually call it the hypertrophy of the olivary degeneration. And this imaging, we usually see it after about 4 to 6 months after the event that the damage to the Guillain-Barré triangle. And once again, I want to emphasize that the Guillain-Barré triangle is one very important neuroanatomical regions in clinical practice. And usually when the primary lesions that affect to the dentatorubral tract that connect the dentate nucleus and the red nucleus is affected, we usually see only one contralateral of the imaging of the hypertrophy of the olivary degeneration. But when the lesions affect the central tegmentum tract that connects the red nucleus and the inferior olivary nucleus, or in some cases the lesion is the SCP, we can see the imagings of the bilateral hypertrophy olivary degeneration. And as you can see in this slide, the palatal there's many causes that cause palatal tremor or palatal myoclonus from the idiopathic, symptomatic, or in some degenerative or in some genetic can cause the symptom. And some new variant that maybe not variant, but the other clinical manifestation can associated with the palatal tremor. In the first video, you can see the patient has the palatal myoclonus, but the patient has some oculomotor abnormality. We can consider ophthalmopsia. Ophthalmopsia is a very disability for the patient with the palatal myoclonus, and in these cases we can cause it the phenomenology of the oculopalatal myoclonus. And in the second video, you can see the rhythmic movement of the left facials of the patient. Also after the brainstem hemorrhagic shock, and she also had the palatal malclonus, and therefore in these cases we can see the patient had a palatal malclonus associated with the facial myarrhythmia, and therefore some authors suggest that the term the line of palatal myarrhythmia. Okay, and how about the treatment of the palatal tremor or palatal myoclonus? Because of the symptomatic palatal tremor does not a major source of disability. Therefore, we don't need to treat those symptoms. But in some cases, the patient has the opsynopsia. We can use the gabapentin or memantine to reduce those symptoms for the patient. But in some idiopathic palatal tremor, we can use the medication or botulinum toxic injections to reduce those symptoms. And finally, before closing my presentation, I want to emphasize again, the Guillain-Barré triangle is very important neuroanatomical regions, and it can but any damage in this region can cause a very various movement disorder. You can see in my presentation from the tremor, from the myoclonus, or some in myarrhythmia, and therefore we need to be recognized early to prevent from the further for the expensive treatment for over treatment for the patient. Okay, thank you so much for your attention.
Thank you very much for Dr. Kang for your very interesting cases, and we have seen many interesting cases from the two speakers, and we maybe it's time, so we end the session now and move to another session. Thank you very much.
Yes, we will have 15 minutes for coffee break, and we will come back at 3:15.